So, greetings to all the PhysioTV viewers. Today, we are having an exciting talk by a person who's right from the other end of the world. Let me take a few minutes to introduce him. And if I really look into the CV, it runs into pages. So, it's going to take more time, but I've tried my best to kind of make it as concise as possible. So let me introduce today a very esteemed and noteworthy physiotherapist who has done his work in India and is now doing a lot of work in McMaster University at Canada. So YV Raghava Nilapalla has been a PhD candidate. He's presently a PhD candidate at the School of Rehabilitation Sciences at McMaster University in Canada. He is doing his PhD under Dr. Lisa Carleso. He's been a bachelor's from NIMS Hyderabad and has done his master's from Manipal College of Allied Health Sciences in Manipal. Been a graduate teaching assistant for the Master of Physiotherapy as well as the Master of Health Management program at the School of Rehabilitation Sciences at McMaster from 2021 to 2024. He's been an assistant professor at the Department of Physiotherapy at Manipal College of Health Professions from 2014 to 2021. He has 25 research publications to his credit and about 314 citations with an H index of an impressive 8. He has attended a lot of international conferences, has been invited as a resource person as well as a speaker. He has received significant funding for his research work. And the noteworthy one is the Arthritis Society of Canada, which is a non government organization. He has had invited talks at Manipal, Bengaluru, as well as UAE. He's been a peer reviewer for many noteworthy and high impact journals, including Musculoskeletal Science and Practice, BMC Musculoskeletal Disorders, BMC Sports Science, Pain Medicine, Physiotherapy Theory and Practice, and Scientific Reports, to just mention them. He has a lot of professional developmental activities which he has participated in, and a lot of courses. And his main body of work lies in pain, understanding pain, and pain management. So I invite you and welcome you, Dr. Raghav, and I guess I pass on the session to you. Welcome.
Thank you so much, ma'am, Sonal ma'am, for your kind introduction. That's been quite elaborate. Thank you so much, and and I also want to thank the for the opportunity to be able to present our work in this platform. And thank you for recording this beyond your work hours. I truly appreciate that and accommodating my time. So I'd like to talk about pain mechanisms and implications for rehabilitation in knee osteoarthritis. So I'll start with my academic background, but since Dr. Sonal ma'am already shared about my background, I'll talk about my PhD research for a moment. So here at McMaster, I'm working on pain phenotypes and their stability and progression in early stage knee osteoarthritis. So we classify these pain phenotypes based on different indicator variables and see different classes and identify which of these classes progress over time. So that's the brief overview of my PhD. And over the years, I've been interested in statistics as well. And currently, my research interest is towards applying different clustering methods to classify patients with knee osteoarthritis. Sometimes some of my friends jokingly call me a spoiled physiotherapist because I'm moving towards statistics, but it's just my research interest. So, moving to the objectives of today's talk, I would like to review the pain mechanisms and evidence for pain mechanisms in knee osteoarthritis, and also discuss the evidence for commonly used physiotherapy interventions on these pain mechanisms. Now, I would like to try to keep a balance between theoretical concepts, clinical utility, and the evidence. And also, I kept the theoretical concepts as brief as possible, but I would like to spend more time on the clinical utility. And a full disclosure that research recommendations are recommendations. It is at the discretion of the clinician eventually to decide on the optimal management. So primarily, I would be presenting the evidence, so which is only a recommendation. So moving to the problem. So as most of us are aware, chronic uncontrolled knee pain is the primary reason why patients with knee osteoarthritis seek medical consultation. And it is also a significant cause for mobility decline in this population. Despite chronic pain being a significant problem, the evidence indicates the present management strategies provide only partial relief, which indicates there is a need to improve pain management in this population, and with a hope that it would eventually result in functional improvement. So first I want to talk about pain sources and mechanisms in knee osteoarthritis. As we all are aware, osteoarthritis is typically considered as the degenerative disorder of the peripheral joints and the spinal joints as well. So knee is the most commonly affected, and cartilage. You usually tend to think of cartilage when it comes to knee osteoarthritis, which starts with cartilage degeneration and eventual erosion. Along with the cartilage, there are other structures within the knee, such as menisci, bone marrow, and synovium, which contains active nociceptors. And these also potentially could be the source of pain. Now, if you look at the commonly identified sources of peripheral sources of pain in knee osteoarthritis, cartilage is considered aneural, and accordingly, it has shown inconsistent association with pain. But currently, the most commonly acknowledged sources of pain in knee osteoarthritis are bone marrow lesions, synovial inflammation, and menisci, or meniscal degeneration or meniscal irritation. So in that order. So most common being bone, or most strongly identified being bone marrow lesions, synovitis, and menisci. And cartilage is usually not considered as a significant source of pain. When you attribute the cause of pain to these peripheral structures, or the pain resulting from the damage to these peripheral structures, you tend to term it as a nociceptive pain, right? So this is briefly about the peripheral sources of pain. Again, I'm not going into the, like I said in the introduction side, I would not go into the definitions and theoretical concepts, but mostly making it more towards, clinical utility towards type of an approach. Now, despite knowing that, okay, these are the sources of pain, as clinicians and also as researchers, we may have seen that the structural changes on imaging may not always correspond to pain. For example, a patient may have severe degeneration of the knee joint but may have very less pain, and also vice versa. A patient may have no degenerative changes on the knee joint but may have severe pain, right? And these structural changes may not be proportional to the pain severity as well. This is not only based on clinical experience, but also the current research indicates that the correlation between the amount of structural changes and the pain severity is not very high. So that made scientists think about what could be the other mechanisms. So that brings us to central mechanisms of pain, which are broadly categorized as central sensitization and psychological factors. Now, I'll go into these one by one. Now, I used the word nociceptive earlier when you attribute the pain to peripheral sources. Now, when you attribute the pain to central pain mechanisms, you call it as a nociplastic pain. And I'm sure there are definitions for all of these terminologies. You can refer, and there are various well-known articles on this topic as well. You may be able to find the references, and I also included the reference list at the end. You may be able to find the definitions there. But I have summarized the important points from these definitions. Moving ahead with the central sensitization. So, as we all know, usually with respect to the pain physiology, Pain originates, or the pain process originates in the periphery. Whenever there is a injury or damage to the peripheral structures, information about this tissue injury or damage moves to the higher centers through the spinal cord and brainstem and to the cortex through the spinothalamic tracts. That's the usual pain pathway. Periphery, spinal cord, brainstem, and the cortical centers. These are the four important structures that are involved in pain processing. Now, what happens in central sensitization? There are a couple of key important things that happen in central sensitization. One, there is amplification of nociceptive signals within the central nervous system. Now, if there is whenever there is a peripheral input, it gets transferred to the spinal cord and above. Irrespective of the peripheral input, there is excessive firing of neurons from the spinal cord itself to the higher centers. Now, here there is a disproportionate amount of firing of the spinal cord neurons corresponding to the peripheral injury. The peripheral injury doesn't matter anymore. There is the spinal cord fires automatically, or when there is a peripheral input, the spinal cord amplifies this peripheral input, resulting in disproportionate amount of pain to the tissue injury. I would like to give one example or one analogy for this central sensitization, or this aspect of central sensitization. Now, say for example, you want to boil the water and you use the fire to boil the water. Now, even if you put off the fire, the water remains warm for some time. So now fire can be considered as peripheral input, and water boiling can be considered as spinal cord injury. And even the fire stops, the water continues to remain warm. Same way, even the peripheral processes, even after healing of the peripheral processes, the spinal cord continues to discharge impulses to the higher centers. But in case of the water example, the water eventually cools down. But in case of central sensitization, they say that this doesn't stop and it's an ongoing process. That is about amplification of nociceptive signals within the central nervous system. And also, if you have to give an additional example, the water boils disproportionate to the amount of fire. You may be using very less fire, but you may find the water too hot. That is what I mean by amplification. Now, the second change in the central sensitization is inhibition of descending pain modulation. A lot of us are aware, like when in a normal individual, when pain impulses go to the higher centers, you have the descending pain modulatory system at the level of brainstem, which exerts its influence over the spinal cord through the release of beta endorphins, and that inhibits the pain. But what happens in some individuals with chronic pain is that there is inhibition of the descending pain modulatory system. It doesn't function anymore. So that is a second change. So because of this, the pain is not only because of the peripheral inputs, it is also because of these central processing that are happening, or impaired central processing that is happening at the level of spinal cord or brainstem. Other than the changes at the spinal cord and brainstem, there is also cortical influences, such as the beliefs of an individual about the pain or cognitive emotional processes. They also exert a top-down control on the spinal cord and brainstem mechanisms. Next, I'll move to the psychological factors. So now, I assume it is now people are more aware about the biopsychosocial model of pain. Maybe when I was an undergrad student, I was not aware, but today I think most of the undergrads are aware of the biopsychosocial model of pain. So which says pain is not only because of the biological factors, it is also because of psychological and social factors. So a list of psychological factors or psychosocial factors are known to be associated with pain or tend to modulate the pain, such as beliefs about pain. What does a person think about pain? Then pain catastrophization, that is excessive worriness about the pain. Then self-efficacy, how much an individual feels confident to perform an activity in the presence of pain. It's about confidence. And then a similar construct is fear avoidance, which involves avoiding an activity with the fear of pain. Next, also stress. Yeah, stress, which is known to have significant association with pain sensitivity and severity. And lastly, sleep quality. If there is poor sleep, it tend to increase the pain or inhibit the descending pain modulatory system, or leading into generalized increase in pain sensitivity. Now, sleep quality may not be a psychosocial factor, but I thought it could fit neatly in there within this group, right? So these are the two aspects: that central sensitization and the psychological factors. Just to summarize what I have said so far, the overall pain experience is a combination of structural factors and central factors. I don't mind to undermine the structural factors. Structural or the peripheral tissue damage do play a role. In addition to that, the central pain mechanisms are also important in overall pain experience. Now, I would like to talk about recognizing central sensitization or pain sensitization. One of the points that I want to say is that there is variable terminology in the literature. People use central sensitization, some use pain sensitization. There's also nociplastic pain. There is a lot of discrepancy with respect to the terminology associated with these central pain mechanisms. The other point that I want to say is that the amplification of the physiological changes, such as the amplification of signals within the spinal cord and reduced functioning of the descending pain modulatory system, these changes are well documented in animal models, and they are also easy to measure using electrophysiological studies in the animal models. Whereas in humans, directly measuring these changes is not practical, right? So scientists have come up with a set of criteria which can serve as a proxy measures for recognizing central sensitization. They are not the direct measures, they are considered as the proxy measures. And that is why there has been a recent term, it is called as human assumed central sensitization. So you're assuming that this person could have high probability of having central sensitization. Now, the last point I want to say here is that, to my understanding, I wouldn't say central sensitization as a dichotomy. You can't classify as yes or no. Another, I would like to scale the participant on a low sensitized to a high sensitized state, on a low to high, rather than creating a dichotomy. Now, here are some of the features that will help us to recognize central sensitization in participants with knee osteoarthritis. So the first one is pain intensity. Now, initially, I have made a list of the subjective features, and in the next slide, I'll talk about more objective features. Subjective features here in this group, the participants tend to have moderate to severe pain. And as I said earlier, they tend to show inconsistent correlation with the structural changes in the joint. That's more straightforward and based on what I have said earlier. Moving to the pain distribution, one of the strongest indicator of central sensitization is that patients have widespread pain above the knee, above and below the knee. Usually, if you ask their area of pain, they say the whole knee, the whole lower limb is painful, that kind of a thing. And I would like to say that if they have widespread pain, that doesn't mean that they have central sensitization. Should not be considered based on one sign, but it is one of the strongest indicators, and it needs to be diagnosed based on a set of indicators, right? So widespread pain is one of the strongest indicators, as you can see in the picture. Next, moving to the behavior of symptoms. Patients with central sensitization tend to have stimulus independent pain, and which is non-mechanical and unpredictable. Now, usually the more characteristic pain in knee osteoarthritis is pain with movement. When patients tend to walk or they do stair climbing, that is when they experience pain. But persons with central sensitization may have constant background pain, and which gets exacerbated on its own without a mechanical event. That is what I meant by non-mechanical nature. It is more spontaneous, unpredictable, and it's mostly a constant type of pain. And this is again one of the indicators. Then lastly, the type of pain would be more of a neuropathic type of symptoms like pins and needles, tingling, etc. So these are some of the subjective markers of central sensitization. Next, I want to proceed to the more objective ones. So if you see the response to treatments, patients with central sensitization tend to have poor response to peripherally acting medication such as NSAIDs and analgesics, and they have more response to centrally acting medications. And as I said earlier, they tend to have widespread hyperalgesia and allodynia. Hyperalgesia is exaggerated response to a normal painful stimuli. So the exaggerated is the key word. They tend to have exaggerated responses to any painful stimuli, and it's not only limited to the knee joint; it is more widespread. If even if you palpate them in a remote joint such as shoulder and elbow, they tend to show hyperalgesia. Next, another feature is allodynia. Allodynia essentially means a non-noxious stimulus also becomes painful. Non-noxious means non-painful stimulus also becomes painful. Say, for example, touch also becomes painful. If you just touch the knee and don't exert much pressure, that becomes painful as well, because not because of the peripheral tissue damage, but because the nervous system that is involved in the processing of pain is sensitized, right? Next, a couple of questionnaires that will help us identify central sensitization. One is central sensitization inventory. I'll talk about it in the next slide. And we have widespread pain index, and you also have pain detect. Next, you have the psychophysical tests such as pressure pain threshold, temporal summation, and condition pain modulation. I'll talk about these in the next slide again. And lastly, you have neuroimaging, based on which you can see the activity in the brain centers that are associated with pain. And if the activity is more, you can infer the cause of pain to be more central than peripheral. And I also understand, neuroimaging is definitely a very resource intensive modality. It is mostly used for research purposes. The feasibility in clinical practices is actually questionable.